Everyone, welcome and thank you for joining us today. It was a pleasure to see you all this morning. My name is Melina Hosseini, and I'm a radiology resident at University of California, San Diego. It's my pleasure today to introduce Dr. Pathria to give this fantastic talk on stress injury of bone. Dr. Pathria is a professor of radiology in the Division of MSK Imaging at University of California, San Diego, where she has worked since 1991. She has been published one book and over 130 scientific papers and chapters. Her honors include the Founders Medal of the ISS and the RSNA Honored Educator Award. Her areas of interest include trauma, muscle, and MR imaging. Her contribution to international health include WHO outreach in Central America and work in Guatemala providing mobility aids to the indigent. We are honored for having her today with us. Thank you, Dr. Pathria, for joining us today. Without any further delay, Dr. Pathria, welcome, and please take it away. Thank you so much.
Thank you very much for that kind introduction, and welcome everybody. This is my first time lecturing for Health for the World. I think it's a great concept, and I'm very excited to participate. I picked a topic of stress injury of bone because it's something that we all see in our practice, and I wanted to dive into it and explain it in a little bit more detail than just showing you a bunch of imaging cases so that you understand what's happening in these patients. So without further ado, why don't we get started? And what I'd like to do first is just talk about what a stress injury of bone is. In our practice now, these make up about 15 to 20% of all fractures. And if you are looking at a patient population that's involved in a lot of sports, especially in elderly patients participating in sports, you may be seeing even more of these. Now, in a typical fracture, we have a single episode of bony injury that exceeds the bone's ability to cope with it, and it fails. But in stress injury, what we're dealing with is multiple episodes of trauma, none of which alone are strong enough to cause the bone to fail. But each of them results in little bits of micro damage, and your body never has a chance to heal it. And that micro damage lowers the failure point, and you wind up getting a stress fracture. It's a slow process and takes multiple traumas for it to happen. Now, when we talk about micro damage, what this really means is at a microscopic level that small cracks and fissures appear in the bone. And once these small cracks and fissures appear, these are well below our resolving power. They're in the micron range. The basic multicellular unit of bone is activated. The bone is resorbed by osteoclasts and then filled in with osteoblasts. So many things can go wrong with this cycle that prevents the micro damage from being repaired. In a normal, healthy body, we experience micro damage to our bone every day with normal activity. And according to Wolff's law, we normally are able to remodel the bone and form bone. So in healthy individuals, you may see cortical thickening. This is a normal response to excessive stress. In this patient who has a short first metatarsal, we see that phenomena in the second. In this runner, we can see cortical thickening. So cortical thickening is a healthy response to excess stress. But when things go wrong and the bone doesn't respond appropriately, the osteoclastic activity outweighs the osteoblastic activity, the bone becomes weaker and it will ultimately fail. So this can happen because the overuse continues. So for example, somebody who's repetitively running, they wind up getting pain, they continue their activity, they'll start first with marrow edema and subtle subchondral failure, and then ultimately that subchondral bone is completely failed, and we have a frank fracture with the fluid within it. The other thing that can go wrong is an inadequate repair response. This is something that we are seeing quite frequently these days in patients that are taking bisphosphonates. So patients that are on bisphosphonates, this entire cycle of communication between osteoclasts and osteoblasts is inhibited, and these patients will not repair. So small amounts of damage will continue and ultimately turn into complete fractures. And in these patients, particularly in bisphosphonates, it takes place in a rather characteristic location along the lateral femoral diaphysis. This is an area in bone that normally experiences a lot of tensile stress. So by tensile stress, I'm talking about bone that's being pulled apart. And this particular type of bone failure is very, very characteristic of this bisphosphonate type of fracture. Now, you probably have all heard in stress fractures this division between the insufficiency and the fatigue type of fractures. In reality, there are often overlaps in individuals because there are more and more elderly people that are participating in activities with repetitive stress. In the pure form, an insufficiency fracture refers to low-level activity being done with bone that is deficient. And it may have a deficient elasticity, deficient strength, deficient repair capacity, etc. But the activity is not vigorous. And fatigue fractures are more vigorous stress applied to normal bone. It's a somewhat artificial distinction, but it's a little bit useful. We'll talk about these as two different groups, but just be aware that elderly people can do sports and young people can have deficient bone. This is a female athlete, and one of the well-known reasons for deficient bone in the young is what is known as the female athlete triad. So this is an overlap type of lesion, and the female athlete triad refers to this triad of eating disorder, diminished bone mineralization, and amenorrhea or disruptions in the menstrual cycle. So that's a classic example of an overlap syndrome. And this term of the female athlete triad is kind of old-fashioned. It's not one that we use anymore. The more current terminology for this type of syndrome is called relative energy deficiency in sport, or RED-S. And it's a better term because these are not all women that undergo this nutritional deficiency from high activity levels. You can see it in men. And the female athlete triad really was just a small part of this relative energy deficiency syndrome. We know that this has much more systemic effects than just involving osteoporosis in the menstrual cycle. Any of our body systems can be impacted by this relative energy deficiency. So this is really the preferred term that's now used for the younger patients very involved in sports who wind up developing multiple stress injuries involving their bone. Okay, I'm going to start by talking about the insufficiency fractures. So as I mentioned earlier, insufficiency fractures are seen due to bone that is failed for some reason. And so since the most common cause for that is osteoporosis, these are seen disproportionately in older individuals, particularly in older women with postmenopausal osteoporosis. There are a few that occur in the upper extremity, but they're relatively rare. The majority of these are going to be seen in the spine and in the lower extremity. So we'll see them in the vertebra. The sacrum is a characteristic location that you should all be familiar with because they're very, very common in this area. They can be seen anywhere along the weight-bearing bones, and there are, again, rarer causes that may involve other portions of the skeleton. I already showed you a bisphosphonate injury, which is a classic insufficiency fracture from failed repair. These were very subtle when they start, often as a little bump or a beak. You may not see a fracture line, and after very minor trauma, the patient can develop a fracture. If you see a transverse proximal femoral diaphyseal fracture, look for this characteristic broadening of the cortex, this little beak. It's a good clue to a bisphosphonate injury, and you have to be very careful and look at the opposite side because the changes are often bilateral. Another classic location for insufficiency fractures is in the vertebral bodies. In the vertebral bodies, about 90% will involve the superior end plate, about 10% involve the inferior end plate, and those are easier to overlook because we're always looking for height loss and superior end plate deformation. These are the diseases that are associated with insufficiency fractures. There are many others, but these are the important ones. Osteoporosis, plus or minus bisphosphonates, prior irradiation to the bone, and then osteomalacia and corticosteroids less commonly, and then the other ones are even less common. So certainly this first two, osteoporosis and prior irradiation to the bone, are the two main risk factors that we see here related to insufficiency fractures. Now, all of you in radiology are familiar with concepts of bone density measurements, and these are often done utilizing DEXA. But be aware that these quantitative measurements are not particularly accurate for determining fracture risk. In fact, they only account for 50 to 60% of the variance in risk for fractures, because bone strength is a much more complicated issue than just the quantitative amount of bone that you have. There are a lot of issues related to the architecture of the bone that determine whether it's strength, what its strength is, what the type of collagen is that you have, the shape of the bone, structural changes that take place with aging, the activity of your metabolic cycles. So true fracture risk is not that well predicted just by quantitative measurements. Unfortunately, we don't have really a lot that we can offer on a routine basis other than quantitative measurements at this time. And the reason that quantitative measurements may not always be that accurate is that they don't reflect the subtle architectural changes that take place with osteoporosis. So these are some images taken from the micro CT group up at UC San Francisco, showing a normal bone. And this is a bone in which the patient has osteoporosis. This patient actually had a total hip arthroplasty above the area that I'm showing you. And you can see that the cortex looks relatively normal, and it looks about the same. But the main loss here is in the cancellous bone. So with osteoporosis, the first bone that we lose is this cancellous bone. This is a micro MR, high resolution, given to me by Greg Chang at NYU, but this is not something that we're really doing in our clinical practice. But be aware of this, that when you have osteoporosis, it's the cancellous bone that fails. You preferentially lose transverse trabeculae and you maintain your major longitudinal compressive trabeculae. And these patients' bone failure starts in this cancellous bone or in the subchondral bone plate. So let's take a look again at the architecture. So this is what an osteoporotic vertebral body is going to look like. You wind up getting big areas of failure in the cancellous bone. And you can think of the cancellous bone as the struts inside a cardboard box. The cortex is the cardboard box. The trabeculae inside are these struts, and these struts are starting to fail, okay? And a lot of things in our life, these struts, they result in markedly increased strength. So this is a toothpick tower. If any of you have to do a high school project and build a toothpick tower, you know that the direction and shape of the struts is what really determines the strength. This is my son's, I think, grade 10 toothpick tower. My husband got an A for his project, so that was good. But you can understand this just looking at your furniture, that if you are looking at stools or chairs in your house, as they get taller, the manufacturers are going to start adding struts to increase the strength because these long columns are going to fail. This is known as Euler's law of buckling, okay? And what happens over here is that when you have a long unsupported strut like this, it really can't take a lot of weight. If you add a few support struts, it's able to take much more load. And what happens in osteoporosis is you're losing these struts. And so activities that you may have been able to do, you could no longer handle and you wind up fracturing. The fracture lines in the longitudinal trabeculae will run perpendicular to those longitudinal trabecules. Like if you break this stool, the break goes in this direction. So this pattern of intramedullary cancellous failure perpendicular to the longitudinal weight-bearing trabeculae is what's really, really characteristic of an insufficiency fracture. The same kind of phenomena we can see in the subchondral bone plate. And again, if you lose some of those struts, you don't have adequate support, the bone starts to sag and it will ultimately fail. Again, the fracture lines run perpendicular to the main weight-bearing trabeculae. And in this location, in the subchondral bone, sometimes these are very difficult to distinguish from avascular necrosis because both entities can show lines in the bone marrow edema, loss of the shape of the subchondral bone plate, and effusion. So we can struggle and then have to rely on history. These are not easy to see on plain films. So here's a patient who has an insufficiency fracture of the calcaneus, very common in older people, especially if they start a new walking program because the constant heel strike and all their body weight is taken by the calcaneal tuberosity. But if you look at this on an X-ray, there's only this very subtle area of trabecular sclerosis running across the main trabeculae of the calcaneus, but very easily overlooked. So bone scan and MR are far more sensitive. And because the fracture occurs in medullary bone, the cortex stays normal and you are not going to see periostitis. When we do fatigue fractures, you'll see periostitis happens early, and it's a really helpful finding for us to make a diagnosis. But in insufficiency fractures, we don't get periostitis, and that makes these fractures very challenging for us to diagnose. I'm showing you a micro CT of a calcaneus with its trabecular pattern. And again, this is an area really vulnerable with repetitive heel strike, where we lose our trabeculae, the constant deformation of the bone will result in these characteristic fractures. So think of cancellous bone and think of subchondral bone when you're thinking of insufficiency. A place you should all know is a risk location for insufficiency fractures is in the sacrum. These can be unilateral or bilateral. They tend to be longitudinal in zone 1, which is the peripheral sacrum outside the foramina. You can see here the edema, but honestly, in a lot of cases, the exact fracture line may be very difficult to appreciate on MR. There's a lot of edema around it. You have a lot of multiple microfractures all kind of coalescing, so the line may not be distinct. But the shape of it and its location in the right demographic group, elderly patient, somebody that's been radiated, somebody who started new activity, should make you think of this diagnosis. And this is the CT obtained a few weeks later, showing the characteristic spotty, linearly oriented sclerosis. Probably all of these little circles that we're seeing are around little areas of microfractures. You can see that they're quite diffuse, and that's why we don't see a very discrete line on our MR examination. These are hard on plain film. So this is the initial radiograph. The patient was already having pain. The X-ray looks normal. This is a follow-up a few weeks later. There's abnormal sclerosis in zone 1 of the sacrum bilaterally. You can see that the arcuate lines are starting to thicken. As you move out peripherally, normally they would thin and fade out, but you can see them all the way out here. There's a little disruption here in the upper sacral ala, but it's hard on X-ray. And if you have a lot of fecal material and bowel gas, you're simply not going to see these. Here's the corresponding CT, again showing linear sclerosis in zone 1 of the sacrum. Now, I had mentioned this subchondral bone to you before. We really didn't know much about these fractures, I'd say, until 15, 20 years ago. So there's a condensation of lamellae underneath the femoral head. And this is a location where we can see these insufficiency fractures. This is a histology specimen taken from an article by Yamamoto, who has written a lot about subchondral insufficiency fractures. And they occur immediately adjacent to the subchondral bone plate. And as I mentioned earlier, it's a really hard thing for us to distinguish these from osteonecrosis. This is the case I showed you earlier, where she started off with what looked like an insufficiency fracture. And this is the same patient several months later. And now it's starting to look like osteonecrosis. She never had a risk factor for osteonecrosis and had started running. So there's kind of a vicious cycle in here where once you get the fracture, it may collapse and you may get secondary avascular necrosis. And so definitely an overlap between these two entities that's difficult for us to tease out sometimes. When these were first described, in fact, these were often referred to as spontaneous osteonecrosis of the knee. We don't use that term anymore. We now know that these are caused by an insufficiency injury, and these are quite common in the elderly where the meniscus has failed. So normally we have this meniscochondral unit where the cartilage is thick centrally and thins peripherally as the meniscus participates in load sharing. If your meniscus is torn, especially if it's extruded, it no longer does the job. And so in patients like that, they will start off by developing an insufficiency fracture. Here we can see the fracture line, lots of edema. And again, in follow-up, things have deteriorated. We now have some small cysts. If you do histology, you will find small foci of necrosis, but necrosis is not the primary lesion in these cases. The primary lesion is an insufficiency fracture. Here's another example showing collapse with vacuum within the bone in a patient with meniscal dysfunction. The meniscus is extruded. And again, remember that this, while it was called spontaneous in osteonecrosis, there's nothing spontaneous about it. And the osteonecrosis, if it occurs, is a secondary phenomena. If you get to it in time before they've collapsed and rest them, these fractures will go on and heal. We can see these anywhere in the body. So I'll show you this case. The patient was a diabetic with an ulcer. There was low-grade osteomyelitis seen on MR that I can't see on the X-ray, and patient underwent an amputation. And she comes in again complaining of increasing foot pain. And so, our eyes are really focused in on looking at the area to see if she's got recurrent infection. But if you look at the second metatarsal, it has collapsed and has subchondral sclerosis. So this is a well-recognized place for insufficiency fractures in elderly women, particularly those that wear high-heeled shoes, particularly those that have long second metatarsals because they take a lot of weight. And this is another example of a subchondral insufficiency fracture. And here's the corresponding MR examination showing there's nothing wrong with her amputation site, but there's a break in that second toe. Another place where we can see insufficiency fractures is when the bone mechanics have been altered. So this is a patient right after surgery. She has a reverse arthroplasty placed. There's no problems with the component. Everything looks good. And here on follow-up, there's a subtle finding that I always look for now in the reverse arthroplasties, and that is this new downsloping of the acromion. So what happens in a reverse arthroplasty is you don't have a cuff working anymore, and your deltoid is working on the acromion to lift your arm. And you can get insufficiency fractures of the acromion. Here we can see the acromial fracture well on the axillary view. It's obscured here by the hardware. It's somewhere in this area. But this is because the mechanics have been abruptly altered in these patients. Another time where we'll see these is in patients when they start to remobilize. So this patient had had fixation of an ankle fracture, had had prior trauma also with some ossicles. This is during the follow-up complaining of increasing pain. Again, we're focused in on looking to see if there's hardware problems, but this patient's developing an insufficiency fracture. The bone gets weak because you've been in a cast. You become osteoporotic from disuse, and then you start walking again. You may start physiotherapy. It's overloaded. And here we can again see on a further follow-up, a little bit more sclerosis from an insufficiency fracture. So there are many, many times the bone will fail, and because of the prior surgery or prior other procedures, we're distracted and we miss the fact that they're developing them. So distal tibia and calcaneus in the lower extremity are the two places we see this most common. I encourage you to focus on those areas for patients that have had an ankle fracture and starting to walk again. Usually we'll see this 2 to 3 months out from the injury when they're starting to reambulate. Okay, now let's turn to the fatigue fractures. Fatigue fractures occur across a broad age distribution. They can occur in the upper or the lower extremity, though the upper extremity ones are much less common. When we see upper extremity injuries, it's either in children who have open physes, and the injuries taking place at the physis, that happens at the humerus and medial epicondyle quite commonly, or they're a real elite athlete doing a lot of sports. Like we can see it from javelin, we can see it from rowing, we can see it, but those people are really, really involved in sports. The vast majority of fatigue fractures are again going to be seen in the lower extremity, and the one biggest risk factor for them is running. So running can cause fatigue fractures of the femur, tibia, metatarsals, and this is the #1 cause that we see for stress fractures in our practice. Let's start first in the upper extremity. So remember, in the child, the weak link in excess activity is going to be the growth plate. It's a relatively weak structure, and they will start to fail across this growth cartilage. And the initial radiographic findings can be very subtle with minimal widening. You may need the contralateral side for comparison. Very subtle areas of bony resorption. But I can tell you this sort of injury at this stage, where we would call it more of an apophysitis than a displaced fracture, is difficult to recognize. You can see the edema here very nicely on the MR examination. So this area and the medial epicondyle of the elbow in young children are both commonly damaged from throwing activities. And in the United States, in particular, baseball is the one sport that does this, and that's why there are so many limits placed on baseball, particularly for pitches, for pitch counts of how often a child can throw on any particular day or week. This is an adult baseball player, and this is an olecranon stress fracture. Again, this is very uncommon unless it's an elite athlete doing a lot of activity. These are easy to miss on X-ray. And basically, if you just remember that the plane of the line goes from the medial epicondyle to the radius, you should not have any normal lucency in that direction, then you'll see this. It can be quite difficult to see on the lateral view. This patient has had some old injury at the sublime tubercle, at the ulnar collateral ligament insertion. He's a pro athlete, nothing else really going on. And here's the MR showing that fracture. They always start here on the medial side and work their way across to the radius. Very characteristic olecranon stress fracture. I see this mostly from baseball, but it is reported in other sports. This is even less common. This is a scapular fatigue fracture. This is also from repetitive throwing. The injury started here, a lot of marrow edema, periostitis, little crack. Patient continued their sport. Again, another picture. And then this is a few months later, and the fracture is completed and displaced. So rare injury, but just to show you some upper extremity. For the rest, we're going to look at the lower extremity because that's really where these fatigue fractures occur most commonly. What happens in these patients? These often will develop after some change in their activity level. So they may pick up a new sport. They may start, for example, running. They may switch from walking to running. So some new or different activity. Other things that can cause fractures, even if they're doing the same activity, is simple things like change in shoe wear. So new sneakers, using sneakers that are too old for high-level runners, running on a different terrain, like moving from grass to concrete. So any of these can set off a fatigue fracture. The activity is usually strenuous, or at least moderately strenuous and repetitive. The classic location is the metatarsals. The most common fracture we see from stress is going to be in the metatarsal shaft, particularly the second, followed by the third and fourth. The first and fifth are less common, and it is in the shaft. So these fractures, unlike the cancellous fractures that I showed you with insufficiency, these fractures start in cortical bone. And cortical bone does not like to bend. It can handle a lot of compressive loading, but it does not like to bend. And they crack start in the cortex. And the nice thing for us is that because they start there, it irritates and lifts the periosteum, and we get periosteal new bone formation. That is going to be the first thing that you see in a fatigue injury of the bone is periostitis. So it's super useful to look for that. So cortical and cancellous bone are really different. They have very, very different biomechanical properties. Cancellous bone over here can bend. It can withstand bending, but it doesn't have a lot of strength with compressive loading. Cortical bone, on the other hand, doesn't like to bend. You know, if you bend it more than 2% of its length, it's going to crack. But it can withstand a lot of loading. So they're really two different tissues that are sandwiched with the cancellous bone inside the cortical bone. So their failure is quite different. So in fatigue, the failure is out here, whereas in insufficiency, the failure is in here. So let's look at just how bone can be loaded, okay? Bone, just these are terms that are biomechanical terms that are not unique to bone. They're true about any tissue. You can compress it, you can pull it apart, which is tension or tensile loading, shearing, and then you can have more complicated injuries like bending and rotation and off-axis shear. So why does the bone bend? Well, it bends because the muscles that attach to the bone are not symmetric. So you may have more pull on one side of the bone than on the other. So if you look at the muscle attachments in a very muscled, high performance athlete, those muscles act on the bone and they lead it to bend. And if you start a new sport, your muscle will strengthen before the bone does. So you can really buff your muscles out over a fairly short time by doing something vigorous. It takes much longer for the bone to heal. So you have an asynchronous response between the muscle and the bone. And I think the tibia is a really easy example to understand that we have a lot of muscle on the back. Your soleus is inserting there a huge muscle, and there's nothing in the front. And if the soleus, as it keeps, contracting, it's going to lead to muscle bending, and there's no counterbalancing taking place in the front. And that repetitive bending leads to high rates of fractures taking place within the tibia. But this is true really of every bone in your body, is that there are differential muscle forces that lead to different bending of the bones. Now, you may have heard of this Fredrickson grading system. It's widely used for grading of stress injury. It was actually developed for the tibia up in the Bay Area. But, so they used it for tibia for young people, but it's become more widely used, and it's now a lot of people use it to describe stress injuries in all locations. I want to go through what's happening in a fatigue injury using this Fredrickson grading system. So we start with normal bone. The earliest injury is elevation of the periosteum with periosteal edema that you can see on MR, and periostitis you can see on X-ray. The X-ray changes develop later. This grading system was designed for MR imaging. Then you start to get marrow edema, and first it's mild, you only see it on T2, then it gets worse, and you see it on both T2 and T1. This is when things start to go wrong, is when you start to see resorptive changes or focal areas of lucencies or cracks developing in the cortex. And then the last stage is where you actually get a frank linear fracture line that enters into the medullary space. It's a good classification system, but remember, it occurs on a spectrum. And so you're going to have things that are kind of in between. Maybe it's a little on T1, I'm not quite sure. You're going to have little cracks that you're not sure if they're really a crack or just one of these lucencies. So it is a little bit of a grading system, but it's a framework that we can use to look at what's happening in the bone. So as your bone is bending and you're getting micro damage, the crack initiation will typically start at the outer cortex. It can happen from compression or from tension. The cracks are a little bit different in terms of their angle, but we can't see that with imaging. That is at a very histologic level. But it'll start in the cortex, and there may be multiple cracks. And it's at this stage we see this characteristic shin splint appearance of mild uptake at multiple sites, often linear in the anterior tibial cortex. There's not really a frank fracture at this stage. Crack initiation, if your body rests, it will heal. If you continue running, the crack will propagate and eventually get into the medullary space. It takes months for bone to completely heal from an overuse injury. So the pain goes away, maybe 6 to 8 weeks later, but your bone is not actually fully healed for about 16 to 20 weeks. So this is very common that somebody rests, they start feeling good, they're not fully healed, they start again, and they once again injure their bone. This is a really early example of periostitis. Notice that this is not the same as just the cortical thickening I showed you from physiologic overuse. Physiologic overuse cortical thickening tends to be much longer and much more dense and solid. You can see periostitis on X-ray. You can see it even earlier on ultrasound. And ultrasound is also very nice because it lets you push on the bone and then you know where the site of pain is. And it takes probably at least a couple of weeks for periostitis to become visible on an X-ray. So MR and ultrasound will show it to you as fluid on the bone surface before you actually see any bone formation. And what's happening here is cracking on the surface, elevating the periosteum. It's easy to miss on MR. This is a patient here that has periostitis, but you miss it because it just looks like vessels. There's no marrow abnormalities. Here's the corresponding bone scan showing uptake in this area. This is the follow-up MR 6 weeks later, and that has disappeared. So when you're looking at the bone in the early stages, unlike vessel, you're going to keep seeing this for multiple slices. So you be careful and look for this kind of halo on your axials and for a few centimeter area of bright signal paralleling the bone surface on your long axis images, because I see a lot of this grade 1 periostitis miss. This is the 2-month follow-up showing the elevation of the periosteum, which is healed in this athlete. Here's another one. This is an adductor stress injury with periostitis. This is from cupping, so just ignore the muscle changes. They're iatrogenic, but there's the periostitis there. Nothing to see in the bone. And this is easier, I think, on a bone scan than on MR imaging. You're not going to see this on an X-ray until it fills in with bone. In grade 2, there are marrow changes that you can see on your fluid-sensitive sequences, but the T1 sequence remains normal. So we have a lot of periostitis in this patient. We have marrow edema, but there's nothing to see in the medullary space. So that would be a grade 2 in the Fredrickson classification. Here's another example. Nothing on T1, edema on T2, maybe a little wisp of periostitis right here along the top of the toe. This is a less common location, but this is a grade 2 injury in a throwing athlete. This is a baseball pitcher who developed these stress injuries of the ribs, which we see not infrequently in the elite baseball pitchers, but also they're described in patients who do rowing. Rowing is a classic sport associated with these types of injuries. The T1 weighted image in this case was completely normal. Here's a little bit of periostitis on the rib on the long axis. Once you move up to grade 3, you start to see changes on T1, okay? And here, there's more edema, obviously, in the tibia on the T2, but our T1 is not normal now. You're starting to see changes inside here, and the cortex is still relatively normal. So in the Fredrickson classification, this is considered a higher grade injury than a grade 2. And then things start to go wrong, okay? Once you get into these grade 4 type of abnormalities, you are actually seeing lucencies or defects in the cortex. I'll show you this patient's X-ray. This has been called the gray cortex sign. And you can see these areas of resorption. They can be very subtle on an X-ray. Here on the MR, we can see the resorptive changes and the marrow edema underneath it. So you're looking for gray holes in the cortex rather than a transverse fracture line. These will often run up and down in the cortex rather than going across. That's a very important concept to understand, is that stress injuries will be deflected and stay intracortical for a very, very long time. And I'll explain that to you as what's going on. So if you took the bone and it was perfectly uniform, okay, we have a perfectly uniform bone, and you start cracking it, the crack is going to keep going. But our bone is not uniform. It has a lot of osteons, a lot of collagen that is oriented longitudinally. And so this gets crack deflection. As the cracks hit these interfaces, they are deflected. And these crack paths in bone will preferentially go up and down rather than across. A lot of radiologists are not aware of this and are looking for the wrong thing when they're looking at stress fractures. This is a fracture, but it's unicortical. It never made it to the medullary space. So this is not rare to see cracks that just stay in one cortex. But I also want to point out that cracks can turn and go up. So this patient is having foot pain now for several weeks. And what started as a little resorption cavity has gone longitudinally in the bone. In the lab, when the bone starts to crack, it's been shown, at least in specimens, that it's about 5 times easier for the crack to go up and down rather than across the bone. And there are many things that lead to this that are known as the strengthening mechanisms in the bone. And the cracks will deflect up along these osteons. And there are also just things in the bone, not just the osteon, but also just collagen fibers at a microscopic level that are all designed to deflect the cracks up. So these are known as toughening mechanisms. And I really want you to be aware of these, because when you're looking for stress injury, instead of looking for a standard trauma type fracture going across the bone, you really need to look for things that may be longitudinal. Here's a good example. Stress injury, everything's running in one cortex, kind of up and down. This is the patient after rest. It's all filled in. Things are looking like they're healing. So, you want the patient to rest here, not after it's already broken. This is a stress injury, and the patient can heal. And so you want to diagnose it at this stage where there are intracortical lucencies, at that 4A stage. We don't want to be diagnosing these when we get to 4B. These resorption cavities can be quite big. Here's a resorption cavity in a runner. This was mistaken for an osteoid osteoma. We've done this a few times now where an osteoid osteoma has been diagnosed, and patient went to surgery, and all it was a resorption cavity related to running. So that's a pitfall. I don't have a great solution for you as to how to tell them. These don't have a low signal nidus within them and with that activity level, but this was one with a very big resorption cavity. This was a second case, a different patient, same problem, where this was a stress fracture, but it was misinterpreted as an osteoid osteoma. The patient went to surgery, had that area biopsied, and it was just a stress fracture. So it's an unfortunate mistake that can happen. This is another longitudinal fracture that takes place. We often see these in the thinner bones. So you can see them in the fibula, you can see them in the tibia and fibula, and they can be very, very long, okay? This is a kid who developed a longitudinal fracture in the back of his femur. It's about a 12-year-old basketball player. You can see a lot of edema. It can look very aggressive. And so you have to be really cognizant of this and look for these sort of longitudinal fractures in the bone, because they're easily overlooked if you're not paying attention. The classic location we see them is in the tibia. Okay, this is a tibial shaft, long area of edema, about half the length of the bone. And there's the fracture. So on your axial images, you can see on sequential slices that there is a longitudinal fracture in the tibial cortex. I think I see these most frequently in the tibia, but I have seen them in femur, fibula. I think I've seen one case in the humerus, but definitely tibia is by far the bone in which we're going to see this. And here's the bone scan, just showing how long the area of uptake is. So be aware of this entity. Now, once the fracture starts to continue, okay, ultimately those longitudinal toughening mechanisms will fail and the fracture will extend across into the medullary bone. But it's a very late stage. This is called a 4B in the Fredrickson classification, where you have a frank medullary line, and it's very late to be diagnosing stress fractures at this point. So we want to be looking for more early findings to be able to make a more timely diagnosis of a stress injury. A place where it's really important to make diagnosis early and where we do recommend MR very aggressively is if there's a suspicion of a stress fracture at the femoral neck, because these are a problem. If they displace, then the patient needs a surgery, and also these are at risk for getting avascular necrosis. They most commonly occur on the compressive side, often near the area of the lesser trochanter, but they can occur on the tensile side as well. One area that you should know about that is normal, that you don't want to confuse with the stress fracture, is this longitudinal band of cortex that is in the bone. This is known as the calcar. It's located anterior to the lesser tuberosity. This is what it looks like on an X-ray. You can see this on your lateral view, sagittal, CT, or MR, or on axial. This is normal. The reason I want to point this out is that many stress fractures start around this area, so you'll see edema, but this is not a fracture line in itself, okay? You have to look for something other than the normal calcar. Your usual stress fracture is going to be located in the medial neck, just above that calcar area. Now, there are other classification systems. I just want to mention briefly. Some people like to use this Keating Miller classification system. It's much simpler than the Fredrickson. And basically, it says that in athletes, there's really no difference in return to play in patients that have pain and edema versus those in which we see a non-displaced fracture line. So maybe we're looking too hard to see if there's a crack. In the Keating Miller classification system, the divide line really between a bad and a not so bad injury is a complete fracture with 2 millimeter displacement. I don't particularly use this system, but it is liked by some trainers because it, lets their athletes go back out and play, even though we can see a non-displaced fracture line in these patients. These complete fractures are actually quite common. That's one thing that I don't find Keating Miller useful, is that I rarely will see grade 4 injuries. I don't want to get to the grade 4 injuries, and we don't usually see these unless the bone is thin. So if the bone is really thin, we might see these, but otherwise they're kind of uncommon fractures. The other way of classifying these is to try to find out which fractures are at risk of complications. So the fractures can be divided into low risk. So metatarsal fractures are considered low risk, even if they're complete. And then there are other fractures that are high risk. And these are fractures that have a tendency not to heal, tendency to allow for displacement, such as spine anterolisthesis or femoral neck fracture, or a tendency to allow for necrosis. So I think this is just a little good list to keep in mind. These tend to do badly. These are the ones that you need to be more aggressive in your imaging to find them earlier, because they tend to have a worse prognosis than the other ones. So let's look at a couple of those. This is a navicular stress fracture. This is almost always in runners, especially people who run on track in circles. It's seen on the outer foot. And they are quite difficult sometimes on X-ray because they start on the dorsal cortex. And if they're incomplete, they're virtually invisible on a radiograph. This one is visible, but most of the time we don't see them. Here's the corresponding MR. And the reason these are a problem is that the blood supply to the lateral navicular is tenuous. It comes from the medial navicular. So like the scaphoid at your wrist, where the proximal pole can become necrotic, here in the navicular, that lateral pole can become necrotic. And here we see an example, CT, of a fracture. This is in follow-up. Fracture didn't unite, and we've lost volume and got some fragmentation in the lateral pole. This used to be called Müller-Weiss syndrome, but now we know that this may be the result of a number of other etiologies. Okay, so going back to Fredrickson, even though it's not perfect, this is the one that I typically like to utilize. It's not perfect, but it's pretty good. And remember that there is a grading of injury here. So sometimes it's hard to know when you want to call it a fracture, depending on the scale of the bone. So just in my personal practice, I call fractures when I reach this stage, when I'm seeing lucencies inside the cortex, and I'll say there's a unicortical fracture without intramedullary extension. That's typically how I dictate those. So what we did today was to talk about what a stress injury is, the difference between insufficiency and fatigue, the difference between cancellous and cortical bone, some of the staging systems, and imaging findings. I hope you learned something from this, and I hope that you see a stress fracture next week and can apply some of these concepts. And I'd like to thank Health for the World for inviting me, and I'm available now to take some questions.
Thank you so much, Dr. Pathria. It was a really fantastic lecture. Thank you so much. I personally have learned a lot, specifically about the insufficiency fracture, the case you showed us about the reverse arthroplasty case with the fracture. Like everything was like so awesome. Thank you very much. So we're gonna wait a little bit for some question to come in, I think. Yeah.
I don't think anybody has any questions.
Yes.
Great.
That was an excellent lecture. Thank you
Thank you very much. Thank you for inviting me.
for joining us today.
Bye.
And I hope everyone have a great day. Thank you very much and goodbye.